Welcome back. It's episode 142 of Grow Yourself Up. And today I'm delighted to be joined by Dr. Judith Herman. So Dr. Herman is a world-famous pioneer in trauma healing. She's really a huge giant in this field. I'm going to read you her bio first, and then I will share a bit about the episode. So Judith Lewis Herman M.D. is senior lecturer in psychiatry part-time at Harvard Medical School. For 30 years, until she retired, she was director of training at the Victims of Violence program at the Cambridge Hospital, Cambridge in Massachusetts in the States. She is the author of the award-winning books Father-Daughter Incest, published by Harvard University Press in 1981, and Trauma and Recovery, published by Basic Books in 1992. She's the recipient of numerous awards, including a Guggenheim Fellowship in 1984 and the 1996 Lifetime Achievement Award from the International Society for Traumatic Stress Studies. In 2007, she was named a Distinguished Life Fellow of the American Psychiatric Association. Her new book, Truth and Repair: How Trauma Survivors Envision Justice, was published in March 2023. In this episode, we talked about both her books. So when I was training as a psychotherapist, we studied trauma and recovery. It's one of the only books I've read, one of the only trauma books I've literally read from cover to cover. It's an incredible book. And she focuses so much about how we need the correct political and social environment to address all types of different trauma. And it's really excellent. And she talks about complex trauma. She is the one who originated the term complex trauma. Bessel van der Kolk then took that further, and both Bessel van der Kolk and Judith Herman tried to get it included in the DSM-4 and 5. It is now as a category in the ICD-11, but there's that book. And then we talked about Truth and Repair, which is her third book. And we had a lovely conversation about mothering the mother, the importance of mothering the mother. She shared a bit about her own experience of motherhood right towards the end. And really, you'll hear her humanity. And this was really a great privilege for me to have so much of her wisdom and to hear, she has really been at the forefront of women's liberation and upholding women. She's done so much for survivors of sexual violence, trafficking, huge, she's got a huge body of work. So I really hope you enjoy this episode, and let's dive in. Dr. Herman, thank you so much for taking the time to be here with us today. I'm really delighted to have you here. Thank you. And when I studied psychotherapy in my own master's many years ago, your book, Trauma and Recovery, was a key text for us. And you helped me understand so much about how important the political and social climate was in terms of trauma healing. I wanted to read something because the listeners are not all professional. So I wanted to read something from your book, from Trauma and Recovery, and then ask you to talk about some of it for us. That would be okay. Can I read you a bit? So, the systematic study of psychological trauma therefore depends on the support of a political movement. Indeed, whether such study can be pursued or discussed in public is itself a political question. The study of war trauma becomes legitimate only in a context that challenges the sacrifice of young men in war. The study of trauma in sexual and domestic life becomes legitimate only in a context that challenges the subordination of women and children. Advances in the field occur only when they are supported by a political movement powerful enough to legitimate an alliance between investigators and patients and to counteract the ordinary social processes of silencing and denial. In the absence of strong political movements for human rights, the active process of bearing witness inevitably gives way to the active process of forgetting. Repression, dissociation, and denial are phenomena of social as well as individual consciousness. And I just find that so powerful, particularly in light of actually what's going on in the world, but also how specifically childhood trauma has been so legitimized in many ways up until quite recently. And I wonder if you could just speak a little bit about this, the need to have a supportive political and social context.
Well, when you're talking about the most harmful forms of trauma, which are not accidents, but acts of intentional violence.
Yeah.
You're talking about crimes. And these are not random crimes, but crimes that serve the purpose of keeping a group subordinate. Whether and that's true whether you're talking about subordination based on gender or based on race or religion or caste or social class. Or whether you're talking about in the political domain, whether you're talking about acts of war or where one national group is trying to subordinate another group, or acts of, say, political oppression, where people are being persecuted for political reasons. And so the violence serves the purpose of keeping powerful people in power. And but violence is not the only method of coercive control. It's the ultimate method. But the people in the dominant group would also they can't continue their dominance without the acquiescence or complicity of bystanders. And so the keeping the bystanders ignorant, not admitting to the reality of the violence, is also an important tool of keeping the powerful in power. We see this going on right now in the US, where the Trump administration is trying to suppress, for example, a famous photograph of an enslaved man, and it's a photograph of the whip scars on his back. And he wants this removed from a national monument because he doesn't want people to know about this.
Yeah.
So, to the extent that you can just deny that this sort of thing happens, you can maintain an unjust power.
Yes.
And so once you're talking about the role abuses of power, you need some sort of, that's a political problem, and you need some sort of political movement to address those abuses.
Yes. Yeah, and it was in the beginning of your book, when you talked about, in the beginning of Trauma and Recovery, when you talked about sexual abuse and hysteria, and how when Freud first linked, when he was looking at young women who he termed hysterics, that was actually all about childhood sexual abuse. But then there wasn't the political climate at that time to look at that.
Uh-huh.
What do you...
I mean, Freud when he published, this was in 1896, when he published his paper, The Etiology of Hysteria, he claimed it was a very, he claimed he discovered the source of the Nile. He likened himself to this intrepid explorer who had solved a great mystery, and he expected that his colleagues would celebrate his findings. I mean, and in fact, what happened was that he was ostracized, and he got the same treatment that survivors would get when they speak out. He was ostracized, and nobody believed him. And so he retracted his findings, not based on any additional evidence, but based on the fact that his world wasn't ready for it.
Yeah. Yeah, and that was so powerful, because I love the way you traced through how the political climate changed in the 80s and the 90s in terms of actually being able to look at domestic abuse and abuse of women and children.
Well, and that was because we had the women's separation movement, and we had women talking first in private in consciousness raising groups, and then going public in speak outs, and taking charge of the research. And so they had, and it was during this period that I came of age, and so all of a sudden there was a movement that would legitimate these kinds of findings. And, sure enough, Freud was right the first time.
Yeah, exactly. And there will be a separate introduction at the beginning, but you've been at your home at Harvard tell us about the Victims of Violence program that you've been running for many, many years. And tell us also about your path to becoming a doctor and what made you specialize in this area.
Well, I can speak to that first. I am a second-generation American-born child of Jewish immigrants from the Pale of Settlement fleeing persecution.
Yeah.
My grandfather, for whom I'm named, Yehuda Bloch, came to the U.S. Alone at age 17 to get away from the Tsar's army. He worked as a salesman on the Lower East Side in New York, and while he studied English and saved money to put himself through medical school, and became a general practitioner on the Lower East Side. So in some ways, I think my fate was sealed before I was born. My mother, his daughter, became a psychologist.
Yeah.
And a psychoanalyst, both a researcher and a clinician. And when as a teenager, I said to her I wanted to be a psychologist like her, she said, "Oh no, go to medical school. You'll have more power that way." And of course, she was right.
Yeah.
And of course, though I didn't know it at the time, she wanted me to do what she probably would have done if she'd been born a generation later, and that is follow in her father's footsteps.
Yes.
So I was already interested in psychiatry when I was in medical school. And when I began my psychiatric residency in 1970, my very first two patients on the inpatient service, where I began my training, were women who had made very serious suicide attempts. And both of them gave histories of father-daughter incest. Now, at the time, the comprehensive textbook of psychiatry, which was the basic text, estimated the prevalence of all forms of incest at 1 case per million. So if that were really true,
Yeah.
What do you think are the odds that the complete beginner would get 2 cases?
It's 2 out of 2, yeah.
Yeah. You know, and not only that, but when they were listened to and not shamed or blamed or disbelieved, but, they had a chance to acknowledge and talk through what had happened to them, they got better. So that kind of set me on a path.
Because your first book was about father-daughter incest.
Yes, a colleague of mine who just finished her psychology degree, Lisa Hirschman. Between the two of us, we in the 70s, we collected 20 cases just by asking a few therapists we knew. Between what the patients we'd seen and just asking around, it wasn't hard to. And so we published our first paper in the mid-70s in a women's studies journal that had just been started. I don't think a psychiatric journal necessarily would have published it at that time. We published our 20 cases, and we started getting letters from all over the country saying this happened to me. And, I thought no one would believe me, and I thought I was the only one.
Yeah.
So
That's so powerful.
wow, something,
Yeah.
So I think it was on the strength of that first book in 1980 that was published in 1981 that I was invited to join the Department of Psychiatry at Cambridge Hospital, which was one of Harvard Medical School's teaching hospitals.
Yeah.
And then soon after I joined the department in 1984, the city of Cambridge appropriated the princely sum of $6,000 for the psychiatry department to develop mental health services for crime victims. And my colleague, Mary Harvey, who's a community psychologist, was hired to develop that program. And she and I began collaborating. She took the role of the director of the program, and I took the role of training director. And we got it off the ground. First of all, by going down to the DA's office and talking to victim advocates and saying, what are the services you need for your clients that you can't get? And then...
Wow, and then you filled all those gaps.
Yeah. We didn't want to, by that time we did have the Boston Area Rape Crisis Center. We had a couple of battered women's shelters. We didn't want to reproduce things that were already available, but we wanted, and so they thought it was wonderful because nobody ever asked them what they needed. And so the DA's office was very supportive. And then we also did a research study just among the clinicians in the psychiatry department to see how many survivors of rape, domestic violence, child abuse they already were seeing on their caseloads. And of course, it was huge.
Yeah.
Percentage of their caseload.
Yes.
But nobody ever talked about it. So, so with that kind of foundation, we were able to build a program that, it was a clinical service program, a teaching program, a research program, and we had also a kind of community education, community intervention arm. And we lasted 38 years. We had, we lasted
incredible.
2022.
What happened in 2022 that you closed? Did you?
Well, this is the state of mental health care we in the U.S. at the moment. Cambridge Hospital was what's called a safety net hospital, public hospital for people who don't have money, don't have resources, don't have private insurance. And mental health care, especially adequate mental health care for trauma, isn't cheap.
No.
It's not at all. It's not a quick fix. It's not, we don't have penicillin for trauma.
No.
It involves long-term individual psychotherapy, group therapy, psychopharmacology, and so on. And so at a certain point, the hospital was losing so much money, they hired an MBA to basically tell the clinicians what they could and couldn't do. Basically to ration care and say, well, why don't you just see this patient for 6 sessions, or why don't you see this patient every 6 weeks,
Yeah.
And so, and they also wanted us to, they wanted to dictate what we taught in our seminars. And so, because...
But you're kidding.
Well, that's what they wanted. Well, because, they wanted us to talk about evidence-based treatment. And we would say, okay, show us the evidence base.
Yeah.
Oh, no, we didn't really mean that. As evidence-based and data-driven has just become business speak now.
Yeah. And it's all about cost saving, because the same thing happens here in the National Health Service in the UK. That's 6 sessions. And I you think you can't even do safety and stabilization in 6 sessions,
Maybe with a nice, uncomplicated auto accident where nobody was harmed. No, it wasn't it wasn't intentional.
Yeah.
Nobody was seriously hurt, but the person has still got PTSD and afraid to drive and so on. Yeah, you can do 6 sessions of the MDR and you're good.
Yeah.
It's not who comes for treatment with us.
No, exactly. Because you are there's so many things I want to ask you about from your first book and your second book, but you are such a huge pioneer in terms of defining the field of complex trauma, complex PTSD.
That's who we see in our, that's who comes for treatment.
Yes. And because that term has really been taken and really expanded massively. So just to say for the listeners who don't know, you coined that term and you wrote it about in your book, Trauma and Healing. And then from what I understand, Bessel van der Kolk took it and wrote more about it and tried to get it into the DSM-5 and was not successful. But it's now been taken from the way that I can see it developing. it includes more categories, like there's much more focus on emotional neglect, not necessarily physical violence. What are your thoughts on that?
Well, I'm glad, the ICD-11, the World Health Organization diagnostic manual, did finally recognize it.
It's included there, yeah.
In, I think 2018. And Bessel and I were both on the committee for DSM-4, where we tried to get it recognized, and then again with DSM-5. And that's a whole story that I don't need to go into, but they kept basically saying, we need more research, we need more research. Well, there's been plenty of research validating the concept. My concept of complex PTSD really relates to the category of people who suffer prolonged and repeated trauma rather than a single impact trauma. And usually what that means is that the person is in a relationship of coercive control, where they are under the domination of the perpetrator. So with child abuse, with domestic violence, with sex trafficking, sexual harassment, hostages, political prisoners, prisoners of war, and so on. Where they may not, they may or may not be physically imprisoned, but they are under the effective control of the person who is harming them. And that kind of relationship, either if it starts early in childhood, it forms the personality. If it starts in adulthood, it deforms the personality. So you see, besides the classic PTSD triad of intrusion, numbing, and hyperarousal symptoms, you see alterations in emotion regulation, in attachment, in identity formation, in relationships. And those symptoms become much more pronounced. And, and so you see symptom categories, from affective disorders, from anxiety disorders, from somatization disorders, from personality disorders, from dissociative disorders. And that was one of the objections that we met with DSM-5, that the symptoms overlap with too many established categories. You said, yes, exactly. That's exactly the point.
Yes.
It's a very diffuse symptom picture. And if you just focus at it, that's frequently misdiagnosed because people just hone in on one of those categories and people say you've got depression, or you've got
anxiety disorder or something.
Yes, that's true. And you're not connecting the dots. You're not putting it all together and tracing the origin of, all the symptoms back to the source.
Yes. And in your first book, you talked about, you mentioned as one of the I can't remember, someone who talked about the disguised presentation, often with complex trauma. that what comes in is like relationship problems or struggles with affect regulation or problems at work. And often what I see is people who have complex trauma but are very polished on the outside, who maybe really worked incredibly hard and so are externally very successful, but inside feel like a young child and have a lot of adaptive coping strategies, which what you talked about, the personality forming. So these adaptive coping strategies act like a shell around the person, but actually they don't know who they are. And then some of that just falls apart in parenthood.
It falls apart in intimate relationships.
Yes. And
because it's within the context of intimacy that they have never felt safe or felt a relationship of mutuality.
Yes.
So how do you establish that when you've never had that? This becomes the challenge. I think, and when you at the extreme end of the spectrum with the dissociative disorders, you have often, you have such extreme compartmentalization that, there's often a so-called host who is the good child, the person who works hard and manages to
hold together, but
function in the world. And then you have these dissociated other parts, child parts and aggressor parts. And what you don't have is an integrated sense of self. As you say, people don't know who they are, or they believe who they are oftentimes the identity is a contaminated identity. I'm dirty, I'm disgusting, I'm bad, I shouldn't have been born. So you have kind of problems with identity and relationship. And then, of course, that's what's challenged in parenting.
Yes. Yeah, and often those parts, because I often ponder the nature of postpartum depression and whether it really is postpartum depression or if it's other parts coming to the fore.
Yep.
And with things like, there's lots of discussion about how anxiety or postpartum rage is considered to be part of postpartum anxiety, but really that might also be a younger part who's, bursting forth now because it can no longer be contained.
Right. Well, I'll tell you a story of one of my first patients, one of my first dissociative disorder patients I treated, had actually done very well in treatment, got out of an abusive relationship, eventually got into a much more compatible, safe, and a healthy relationship, and eventually got married and moved away. And it sort of felt like a success story.
Yeah.
And then a couple of years later, maybe 3 years later, she came back into treatment. And she was so ashamed. She sort of felt like she'd flunked therapy because she'd had a baby. And things were fine until the baby reached toddler years, became a pet, and discovered the word no. And she started to have these intrusive images of throwing this kid against the wall. And she was so horrified. And, so she came back into treatment. And before long, what she said was, now I know what happened to me.
Wow. Yeah, that's so powerful and so devastating. And I think that my view is that a lot of this stuff, that there's such a range of complex trauma and what you call dissociative disorders. Lots of people wouldn't get the category of a disorder. They wouldn't maybe fill the criteria, but there's a huge amount of us who may swing between dissociation and rage because our window of tolerance is too narrow. And so then so much shame can come in parenting because of all of that. And what you said about the toddler, because I think for many of us, particularly if there's emotional neglect involved, the huge volume of feelings from small children can be so invasive.
Right. And if you've been dealing with feelings mainly by numbing out.
Yeah.
Because they feel unmanageable.
And unsafe.
And then what are you going to do when you have a crying baby?
Yeah.
That needs to be soothed. One of the things I think that my colleague, I have a colleague, a psychologist named Carolyn Lyons at Cambridge Hospital. She had an amazing 30-plus year prospective longitudinal study of what were called high-risk moms and their children. And it started, they were just, the high-risk moms were referred by the pediatricians, either for postpartum depression or substance abuse or being in an abusive relationship, some sort of something that came to the pediatrician's attention that made them worried about how this mom was doing. And the kids were, and the study was randomized in 3 arms. The first group got weekly home visiting for the moms from a social worker. The second group got weekly home visiting from a woman in the same community who had a reputation as a good mom, experienced mom. And the third group just got pediatric care as usual. And the home visiting went on just till the kids were 18 months old. And the home visiting staff, their job was to just offer some education about normal child development.
Yeah.
But also just to help the mom with whatever she needed, if she needed help with housing or, getting
emotional support. Yeah.
Just basically to nurture the moms so the moms can nurture the kids.
Yeah.
And and this just went on till 18 months. The 2 intervention groups, and then they followed the kids throughout the course of their development.
Yeah.
And now they're following the next generation. Kids and moms, children.
That's incredible.
Yeah.
What a beautiful study.
And what they found was that the 2 groups that got the home visiting, the kids did fine. They formed secure attachment. the moms, they just needed that support.
Yes.
And they were able to then offer the kids the support that they needed, and the kids formed safe attachment. So secure attachment. The kids,
and was there any?
And the kids in the pediatric care, as usual, struggled. Yeah, on every dimension, in terms of physical health, mental health, school achievement, social development, and so on.
Yeah. That's such a beautiful thing to hear, Judith, because that's actually the purpose of this podcast, is to mother the parents, father and mothers, because when we haven't had that, we're mothering we're mothering often because when we are insecurely attached, and so we have very active shame voices and very active perfectionism. So we constantly our own worst critics, and we're desperately trying to get everything right. But we have a nervous system who is just not built for, even regulating ourselves. So we struggle with the regulation of the child. But in that study, was there any difference between those who had been visited by the social worker or the community member? Or was it?
No, actually, both intervention groups got weekly supervision as a group, the social workers did and the community moms. No, the two intervention groups there was no significant difference. The women said about the social workers were typically things like, she was very kind. And what they said about the community women was like, she's like the sister I never had.
Beautiful.
Yeah,
so beautiful.
No, we have so much. There have been a bunch of studies like this that just document the effectiveness of, early intervention for first-time moms, for high-risk moms.
Yeah.
Helping them and helping their kids. And it's cheap.
It is. It really is. Yeah, it really is. And I think that the term, to me, the term high risk immediately triggers shame in me. And yet I think I was a high risk mom, and I think lots of listeners are high risk moms that we've got on this podcast. And I really kind of want to normalize that, because when you haven't, well, not normalize it, but when you haven't received what you need in childhood and you've got alcoholic parents or emotional neglect or sexual abuse or child abuse or whatever has happened, then even though we try, because I often say that there's a cruel paradox that those of us who most want to do things differently are often the ones who are least well equipped to do it.
Well, and not only that, but at the highest risk of teen pregnancy.
Yeah.
And that's well established in this kind of longitudinal studies that, early puberty and early pregnancy are, for abused kids, definite risk, they're higher risk.
Yes. Yeah, so there's so much. Wow, there's so much. But I love that the validity of demonstrating that mothering the mother makes all the difference to all these outcomes.
Absolutely. And it's one of these things where, from my point of view, the best public health intervention you could imagine would be to offer this to every new mom.
Yes, exactly. No testing or no, exactly.
And it would pay for itself 10 times over.
Exactly.
And, but politicians don't think about the long, down the road. They think about maybe a 2-year election cycle. It's not going to pay for itself in 2 years. It's going to pay for itself in 20 years.
Yeah.
But it's going to pay for itself 10 times over.
It is. Yeah, because think of the reduction in all those diseases that are correlated with ACEs, for the children of the people who get the intervention. It's the most incredible thing. We'll probably see the collapse of
mental health care, other social services, policing. I mean, you name it.
Yeah, exactly. We'll probably stop working so hard because we'll stop trying to prove ourselves because we don't have to escape. No. Anyway, okay, let me ask you, because I'm just conscious of the time. Can you tell us a bit about your stages of recovery? Because I think that's still so important and really influenced how I work in terms of, working with trauma.
Well, what I proposed in trauma and recovery is to think of recovery in 3 stages. And that I don't mean that these are cast in stone and that you just kind of frog march from one to the next. They're really more in terms of the emphasis of the therapy work. And the first stage that I proposed is safety and self-care. And there, if you're not safe in the present, then you don't have post-traumatic stress disorder. You have an ongoing traumatic stress disorder because you're still at risk.
Yes.
And so, and
I love the way you talk about restoring power and control in that stage to really give a sense of agency.
Right. If you're under the domination of another person, then you don't have safety, you don't have power, you don't have control. And in order to process trauma in the past, you have to be able to draw a clear distinction emotionally between that was then and this is now. So you have to have some sort of gut feeling that now is not the same as when you were helpless and terrified and isolated. And so from my point of view, establishing safety was a precondition for all the subsequent work. And that means safety in the body, starting off with the body, because if you don't feel safe in your body, you don't feel safe anywhere. That means restoring biorhythms that have often been disrupted, sleep, eating, exercise. It means attention to things like money.
Yes.
And housing and
your context.
Yeah, and social support, because safety is not something you can establish in isolation. So you start there, and then at a certain point, people are ready to do the trauma processing that basically focuses more on the past and telling the story and making meaning of the story. And people are grieving the losses. And people think that, they're afraid that's just going to go on forever. But it doesn't. At a certain point, people just say, you know what, I'm just not that interested anymore. I'm more interested in something that's going on in the here and now, or people come back to focus on the present and the future, but more from a proactive stance rather than a defensive stance, which you have.
Yes.
In the first stage. So, we at the Victims of Violence program, we developed 2 different kinds of groups. One, which our stage 1 group, which is a more psychoeducational group about trauma and its effects, and people bond more around their symptoms and what's going on in the present. They don't go into great depth in talking about what's happened to them.
Yeah.
Our stage 2 group is more trauma focused, and people do some trauma processing. We don't have a stage 3 model because in stage 3, you can have a wider world. In the early recovery, you might feel that the only other person who could possibly understand you would be another survivor who went through something very similar.
Yeah.
By the time you're in stage 3, your suffering is one kind of suffering.
Yes. And you call that reconnection with ordinary life.
Yeah. Yeah. And you can imagine that a much broader range of people could understand you and support you. And you could also understand the broader range of people.
Yeah. And I think that, if someone's listening to this, and because some people don't realize, especially if you have what we talked about earlier about that disguised presentation, you may think you are really high achieving and very kind of successful, and be surprised, not be really aware of how poor your affect regulation is or how poor your relational skills are. And then if you come into motherhood, which seems to happen quite a lot, and it kind of completely blows you apart because it's so shattering to your sense of self and your identity, and suddenly you can't work, which is the area, your self state or your part where you were most competent, and now you're looking after this baby. In those cases, and often complex trauma work is you can't really do in the first year postpartum that much because you really have to focus on safety and stabilization. But if someone is not even able to do therapy, what do you think are useful things for them to do for themselves to facilitate that safety and a sense of stabilization? Do you have any ideas on that?
Well, we encourage people to think about who they can turn to safely for support.
Yeah.
It doesn't need to be a therapist. Some people just don't have access to therapy.
Yeah.
But, is there somebody you can trust? Do you know how to make a friend?
Yeah.
And, sometimes people aren't in therapy, but they can join a self-help group.
Yes.
Sometimes, where alcoholism is such a frequent complication of trauma, or where family members, children of alcoholics, are so frequently traumatized. A lot of people find support in 12-step programs.
Yeah, that's true. I found a lot of support there myself. Yeah.
AA or Al-Anon or
ACOA.
Yeah. And so it doesn't have to be formal therapy, but just don't try to do it alone.
And asking for help is not because, if someone's learned to be hyper independent in their family of origin, then it can be really shattering to one's sense of self to even ask for help. But this is a time, postpartum is really a time to ask for help. Do you have time for one more question, Judith? Or two more questions? Rushing onto your other book, because I love this book, Truth and Repair. So that's your more recent book, published in 22. And this really focuses on survivors of sexual, sort of like a huge range of sexual kind of crimes. And I love your model about how you talk about accountability and apology. And this is such a rich text for people. What I was really struck by is your very current examples of like Pornhub and how people are exploited so badly with that. And then also you mentioned an example close to home where a professor in your own university in Harvard had been accused of something, and how people in his faculty wrote a letter of support without knowing any of the details of what he was being accused of. How do you, as a woman, maintain a sense of hope and kind of purpose that things are going in the right direction when this is so much all around us and continues to happen?
You have to take a long view. The subordination of women is maintained worldwide by violence. The United Nations now finds that gender violence is the most common form of human rights violation in the world. And this has been going on for a long time. There's a British psychologist named Juliet Mitchell who wrote a short pamphlet years ago called Women, the Longest Revolution. And she tried to explain why women's liberation was a lot more complicated than, for example, just liberating the working class. She said the working class is oppressed in the domain of production. Women are oppressed in 4 domains: production, reproduction, sex, and childbearing.
Yeah. And
in order to make progress in the status of women, you need progress in all 4 domains.
Yes.
And sometimes you'll see progress in one, but backsliding in another. And so it's so that's why she called it the longest revolution. So,
well, you talked about community in your book. Actually, you talked about your community of colleagues and being in touch with like the joy in your own life and the kind of held in the warmth of community there to kind of hold us up.
Right. Just like, just in the way that survivors can't recover alone, we professionals can't bear witness alone.
No.
If we're going to do that, we need our own support system. And, then if you have that, you have a shoulder to cry on when you need it. And you also have people to celebrate with and have fun with.
Yes.
And to remind you that, the worst that people are capable of is not the whole story,
Exactly.
And so that, the Victims of Violence program has been that home base for me. And I think and then the other thing that you see that keeps hope alive is that a lot of patients get better.
Yes. Yes.
Well,
it's very beautiful work doing this. It's a real gift.
Yeah.
And I just want to ask you about, this book is really a manifesto about reimagining justice for trauma survivors. And you've got some such powerful case studies. You've got a lot of case studies in here. How did you, like all of that work, do you want to just tell us a tiny bit about that? If you've got time in the book.
I can just, basically, it's much the way Lisa and I did the research for
There were 20 cases.
Incest book,
Yeah.
where we just kind of put out the word among colleagues. And, do you have any incest cases, or do you have any incest survivors who are willing to be interviewed? I put out the word among my professional colleagues. Do you have any survivors, who would like to talk with me about their ideas of justice? And the question I asked was, if you could write the script, if you were in charge, what would make things right, or as right as possible for you? And I got 30 people, 26 women and 4 men, who were survivors of sexual assault, sexual harassment, sex trafficking, domestic violence, child abuse, or child. And they were a pretty diverse group on many demographics: race, social class origin, religion, geographic origin. They were, as a group, more highly educated than the general population, and also a much higher percentage had actually had experience with the justice system, either civil or criminal, but they had actually sought justice in one form or another, and not necessarily successfully. And so it was a convenient sample, and I can't claim that that's in some ways, is a demographically representative sample. But there was remarkable unanimity.
Yes.
I mean, they weren't all the same by any means, but the take-home message was they weren't big on punishment, and they weren't big on forgiveness.
Yeah.
They wanted accountability. They wanted acknowledgement, accountability, and amends, and they wanted those as much or more from the bystanders,
Yes,
as from the perpetrators. And some people actually got that. Not many, but some did. And
I love the stories where they did get that in here. And that point that you made about that they're not big on punishment, that actually gives me hope about what makes people feel that they've received justice. It's not, it's interesting, it's not an eye for an eye, is it? It's that they want.
A lot of people would say, I don't see how that's going to help me.
Yeah.
They wanted the support and acknowledgement and affirmation for themselves. They wanted the bystanders to step up and say, that never should have happened. That was wrong. You didn't deserve that. And we're going to hold this person accountable and make sure he doesn't do it again.
Yes.
And that was much more meaningful to them than, punishing the perpetrator in and of itself didn't help them.
Yeah. Didn't help them. Wow, it's very beautiful. I really recommend this book to people. And Dr. Herman, I'm conscious of the time now.
Yeah.
And I know that you are also a mother.
Yes.
What would you...
mother.
And a grandmother. How many grandchildren do you have?
Well, my daughter has 2 and my stepson has 2. So that makes 4.
Oh, wonderful. Are any of them babies?
What?
Are any of them babies?
No. They range from 4 to 12.
Wonderful. And what would you say to mums listening? What would be like something that helped you in your own motherhood journey? when you mothered your daughter and maybe your stepson as well?
Oh gosh.
It might be a long time ago, I know.
Hanging out with other moms was a big help.
Yeah.
Again, having a support system. I had my best friend had a baby 6 months before I did. She came over to visit when I was still sort of like in that what just happened stage. She said, "I'm going to prepare yourself for a shock. It's a baby, but it's the wrong size." And she showed me her 6-month-old. And it's true. He was like, "Oh my God."
Was it a giant baby or a
Giant baby.
I love that. It's so humanizing to hear, you're a world famous psychiatrist. You've written lots of books. You've written hundreds of papers. And for you also to acknowledge that motherhood is a shock.
Oh, totally. Totally. Yeah. Wow.
So thank you. This has been a deep, deep honor and pleasure. Thank you so much for taking the time to be with us.
Well, my pleasure too. Thank you for the work that you're doing. It's very important.
Thank you. Thank you so much, Dr. Herman.
Take good care.